Next, I call upon Dr. Harshali Kamat. She'll be talking about B scans. So, Dr. Harshali is a senior vitreoretinal surgeon working in Trivandrum. She completed surgical vitreoretinal fellowship from Shankar Nethralaya, Chennai.
Good morning, everybody. I'm Dr. Harshali. As Dr. Sharath was asking, are these imaging still relevant? I think ocular ultrasound still plays a very important and a relevant role even in a general ophthalmology clinic. I won't go into the physics because of the paucity of time and will lay more stress on the pattern identification of different conditions and the techniques involved. So it's a go-to imaging in opaque media in cases of mature or advanced cataract, in cases of vitreous hemorrhage, corneal opacity, hyphema, hypopyon, small pupils, retrolenticular or pupillary membrane, and in cases of inflammation. There are other indications in clear media, but they're more in retina clinic. Now, the for using the techniques that we use commonly, you have to lay stress on the probe marker. Based on the probe marker, you can decide on the topography. So you have three types of scans that you do: the transverse, the axial, and the longitudinal. Coming to the transverse scan, the probe marker is placed parallel to the limbus, and it is very important for showing the circumferential or the lateral extent of the lesion. In cases of axial scan, you place the probe marker over the cornea, as in this case, and you can do it either in the horizontal direction or in vertical. In longitudinal scans, the probe marker is placed perpendicular, as you see in this image, and that shows the lesion's anterior posterior extent of any lesion. Now if you're doing a general screening, then you can do the 4 transverse scans, the 2 axial scans, or one of the longitudinal. Now let's come to the pattern identification. In posterior vitreous detachment, you will get a low to moderate reflective membrane. Most importantly, it will have good after movements. It can be attached either to the disc or any part of the retina, wherein it will be called an incomplete PVD, or if it is completely detached, then it's a complete PVD. Sometimes you in vitreous hemorrhage, the posterior hyaloid might appear very high reflective, in which case you may have to differentiate from the retinal detachment based on its after movements. In vitreous hemorrhage, in case of fresh vitreous hemorrhage, you may see a dot or clump like echos, and you have to remember to do it also in the higher gain. As the vitreous hemorrhage ages, it becomes more organized and you might start seeing membranes and clumps. You may have PVD associated with it, and sometimes you may have echos behind the hyaloid, which will be the subhyaloid echos. You may have vitreoretinal adhesions, and that can give rise to tractional detachment. Sometimes you may see splitting of the vitreous, which we call as the vitreoschisis, and it's important for the retinal surgeons because then they have to look out for the second membranes during the vitrectomy. There are several mimics which we need to know. One is asteroid hyalosis because it's so common, and you have to differentiate it from the vitreous hemorrhage. These are high reflective discrete echos, and very commonly you will see a clear space between the asteroid and the retina. Sometimes you may see a closed funnel RD and completely miss the central stalk, as in this case, in which case you might mistake it for a vitreous hemorrhage. Endophthalmitis I will discuss in the later slides. As I was saying, the previous closed funnel RD, if you miss the stalk here, then you might assume it to be a vitreous hemorrhage. Coming to retinal detachment, here it will be a high reflective membrane echo, and it will persist in low gain as long as the probe is perpendicular to the surface. It will have poor after movements, and if it becomes long standing, it will lose its mobility and may have a funnel shaped configuration. Sometimes you may have this unusual echographic finding in case of giant retinal tears, where you'll see double membrane folded over itself. Exudative RD, you may demonstrate shifting fluid either in sitting position and then supine position, where you can demonstrate the fluid being shifted. you may have associated retinochoroidal thickening. In tractional detachment, you can have various type of configuration. You can have a mild focal detachment. You can have a tabletop configuration at the posterior pole or a hammock-like configuration. A small dome-like high reflective membrane in the periphery is suggestive of retinoschisis. Choroidal detachment will be high to moderate reflective dome-shaped echo in the periphery. It will have no after movements or very minimal, and sometimes you may be able to demonstrate this thin line, which is the vortex membrane. On a A scan, you may have a M-shaped spike. To differentiate whether it is a hemorrhagic or serous, you may find these suprachoroidal dot echoes in a hemorrhagic. Coming to infections and inflammations, in endophthalmitis, if you see a cobweb like echo along with these dot and clump, it's more suggestive of inflammation and endophthalmitis. There'll be sub-highlight echoes if there may be associated PVD. If it is progressing to panophthalmitis, you may have localized subtenon's widening or in advanced cases the T sign, wherein you see this subtenon space widening along with the optic nerve shadow of a T sign. In scleritis, again, you may have thickening of the sclera with an associated T sign, which I demonstrated earlier. Cystic is a very typical ecolucent cyst with the ecodense nodule within it and very characteristic of cystic. Coming to trauma, which is also a common indication for ultrasound B scan, we usually don't do it in an open globe, but in a blunt injury, you can see a subluxated lens, you can see a dislocated IOL, a high reflective echo in the mid-vitreous cavity. You may have vitreous hemorrhage along with scleral dehiscence and vitreous tracking to it, suggesting of vitreous incarceration. Other features may also be present, such as retinal detachment or choroidal detachment. Sometimes you may see a widening of the optic nerve shadow in cases of optic nerve head avulsion. Intraocular foreign body may be seen as a high reflective echo, persisting in low gain and causing shadowing. There are certain tumors which you need to be aware of. Most importantly is the retinoblastoma, where you shouldn't, if you see these calcification, it is very characteristic and shouldn't be missed. Choroidal hemangioma, a circumscribed one, will be seen as a dome-shaped mass with high internal reflectivity. The diffuse one will not have a specific mass, but just a diffuse high reflective thickening. Melanoma may have a collar button shaped appearance, and you may demonstrate you may show choroidal excavation with scleral bowing. Metastasis may have a lumpy, bumpy appearance with exudative RD. Certain pediatric condition and advanced ROP with closed funnel, you may find this high reflective echo. There may be different types of configurations, such as anterior open or a posterior open, which you need to document. Coates disease won't have any particular mass lesions, but you'll be able to show the mobility of these subretinal echoes and forms an important differential for retinoblastoma. But if you see calcification, it's more towards the retinoblastoma. There are certain abnormalities, anatomical abnormalities, which you need to know, such as if you see a smooth excavation, it's a posterior staphyloma, whereas if you see a sharp excavation, as in this case, it's a coloboma. It may be associated with a retinal detachment. The optic nerve head cupping more than 0.7 can sometimes be demonstrated on the B scan. A high reflective echo at the optic nerve head, which persists in low gain, can help you differentiate between a papilledema and a pseudopapilledema in case of optic nerve head drusen. Sometimes in post-vitrectomy surgery and you have a mature cataract and you see certain features like enlarged globe, apparently enlarged globe with the oil meniscus, it's an oil-filled eye. Post-SOR, you may find discrete echoes in the midwit cavity. Thank you.
Thank you, Harshali, for a very exhaustive talk on ultrasound.